Good morning, everyone. My name is Michael Mansour. I'm one of the ID faculty. Welcome to the course again. In this 45-minute lecture, I'm going to go over some of the immune-based therapies for malignancy that you and I, as infectious disease consultants, will certainly encounter in our practice. And so this short lecture is intended to go over the basics of what these cellular and immune-based therapies are, a little review of the immune system, and hopefully this will lay the groundwork for additional lectures you'll hear in this during the course. These are my disclosures. And so the talk is really set up around two of the main immune-based therapies that you'll encounter. There are several at this point in the world of oncology, but I think the two that you'll most likely encounter are molecules called checkpoints, checkpoint inhibitors, and then cellular therapies like CAR T-cell therapies. Both of these have grown in impact in the oncology field in multiple types of tumors and cancers. And as an infectious disease physicians, we will certainly come across patients who have received one or sometimes both of these therapies. So to understand these, the first point I'd like to review is what's the normal immune reaction, and then how do these two types of therapies interfere or augment that immune reaction for a better oncology outcome. So the talk is in two parts. Let's talk about the immune checkpoint inhibitors. So what is an immune checkpoint inhibitor? I'm going to ask a question here. Please think about that answer, and then after the first talk, the first part of the talk, you should be able to answer this, and I'll reveal the answer. But to go over the choices, an immune checkpoint inhibitor regulates the intensity of an immune response. Or B, an immune checkpoint inhibitor interferes with down-regulating surface molecules on immune cells to enhance immunity. Or C, these immune checkpoint inhibitors directly kill tumor cells. Okay, so let's think about these three choices, and then we will reveal the answer at the end. So let's start with what the normal immune reaction is. What happens when we encounter a tumor cell or a pathogen? And so we've, over time, divided immunity into two branches. And we do this only to be able to think about this very complex organ structure, the immune system, and parse it out in our mind. But I'd say the most popular, the most common approach is to think of the immune system as having an innate and an adaptive branch. The innate branch has very, sort of characteristic responses. It's a very fast responder. The innate immune components can respond in the order of seconds to minutes to hours, whereas the adaptive response is incredibly slow. It may take days, weeks for an adaptive response to occur. The innate immune response is nonspecific. It doesn't know whether it's responding to E. coli or Pseudomonas or Shigella. It just knows gram-negative. It can see as a pattern on the cell wall of these bacteria, but it doesn't actually have a specificity to one or more of these types of pathogens. Whereas the adaptive response is incredibly specific. It knows the exact protein antigen, the epitope on E. coli, and it's very directed to that specific molecule. Who is what composes the innate immune response? There are cellular and non-cellular components. Cells include neutrophils, our most common white blood cell that circulates, macrophages, monocytes, dendritic cells, eosinophils. These are all cells that compose the innate immune response. These cells are all fast and they're nonspecific. They don't actually know what they're responding to. They know that in general, this is a foreign pathogen that needs to be dealt with. The non-cell components of the innate immune system include complement, mannose binding lectin, and C-reactive protein. The adaptive immune response themselves are simpler, so to speak, because they're really composed classically of T and B cells. And then B cells produce antibodies, and antibodies are the main dominant component of the non-cellular adaptive immune response. So fast and non-specific, very slow but highly specific. Okay, so when we have a cellulitis, when we have a new onset of an infection, we want a very rapid innate immune response to control that infection, while we allow the adaptive immune response to really produce a productive T, B cell response, and antibody response that may take days to weeks. Okay, and that's what vaccinology is all about. The vaccine technologies that we all use and provide our patients couple innate immune recognition with the goal of driving that adaptive, long-lasting B cell response, for example. So here's a little pictogram of like how this works. This comes from one of my favorite textbooks, Janeway. And so here's a cut in skin. This is the outer surface. This is the inner surface of skin. Bacteria have now seen an opportunity to infect deeper tissue. You have macrophages and dendritic cells, which non-specifically recognize that there's a foreign pathogen. These cells will engage lymph vessels and drain to a draining lymph node, where within the lymph node, there's antigen presentation, and they will process and chop up these little pathogens to present to the adaptive immune response. For example, T cells in the lymph node, which will proliferate, grow, and then move their way through the lymphatic system back into circulation and return to the site of infection. So this is from rapid, fast response all the way to weeks later having, that adaptive immune response in one sort of pictorial example. So what happens when this dendritic cell drains to the lymph node and it's trying to find that very specific T cell? And so what happens there is something called the immune synapse. So here in this wavy green line is a representation of a dendritic cell. And it's presenting the processed, chopped up, Staph aureus that just entered our skin and is presenting it on MHC. And it's incredible, but it does find that very specific T cell that contains and expresses a T cell receptor specific to Staph aureus epitopes presented on that MHC complex. Okay. Now to activate this T cell and have it proliferate and respond to the infection, there must be three signals that occur. The first one is the recognition of this very specific epitope on MHC engaging the T cell receptor. That we call signal one. Without the other signals, this T cell would then become anergic. So you must continue to go through the second and the third signals to get a full T cell activation process complete. So signal two can come in a variety of forms, but the most common is the engagement of B7 and CD28. B7 or CD80 comes from the antigen presenting cell, and that'll engage CD28 on the T cell. And this delivers another signal downstream into the T cell, which continues to activate that T cell. So now you have recognition of a specific epitope, you have signal two, and then the third signal, there's three signals, remember. The third signal is a specific cytokine, and the antigen presenting cell will secrete in this tiny little space of the two membranes touching another cytokine that will polarize a CD4 cell. Here it says CD8, but really it's a CD4 cell, and it will force the cell to become a Th1 or a Th2 or a Th17. And so this specific cytokine directs the T cell to become a specific type of cytokine producer, a specific type of responder based on the infection that this dendritic cell has encountered. So once these three signals are delivered, you have an active T cell, which will now proliferate and grow and really begin to respond. Now, all good things must come to an end. And so once this T cell is active and the infection is under control, we must stop the reaction. And so T cell activation can't continue, for in infinity. It must stop. And so the immune system has built a series of gas pedals and brakes. The gas pedal is signal two, like we just reviewed. it's CD80 and CD28. So in this cartoon, you have the antigen presenting cell, like a dendritic cell, presenting the antigen. This is signal 1. And then signal 2 is CD80 and engaging CD28. This is signal 2. Okay. Now, to shut this down, we need to tap the brakes. After this infection is controlled, after the infection is resolved, we must stop all this T cell activation. So those brakes are called checkpoints. In this picture, a very common example of a checkpoint it's encountered is CTLA4. Now, CTLA4, the way it works is that CTLA4 has a higher affinity for CD80. So instead of getting a continuous signal through CD28, which is right here in this picture, CTLA4 kicks off CD28 and occupies the site of CD80. So you no longer get a signal 2 coming through this T cell, and without signal 2, this T cell shuts down. So this serves as a checkpoint. It's a checkpoint for activation, okay? And so if I inhibit this checkpoint and I use a checkpoint inhibitor, I will, in essence, get an unchecked, continuous T cell activation that just persists for a very long time and really grows into much higher levels than normally would be expected. And if that antigen that this T cell is responding to happens to be a cancer antigen, then what you really have is a really fantastic tumor response. So CTLA4 is right here, and this is one checkpoint. But look at the number of checkpoint inhibitors, checkpoints that we have that are available to be inhibited. And in fact, all these stop symbols here are indicating evidence that you can inhibit these. We've done this through, the scientific groups have inhibited these, and we see that they're not all created equally. They all have some nuances to them. But in general, the take-home message is if you take away that checkpoint, you will now, what you'll result in is a very vigorous T cell activation that is really going to go to a much higher level than normally expected. And so, what checkpoint inhibitors are monoclonal antibodies. The way you inhibit these checkpoints is you add an antibody, and these antibodies bind to the checkpoint and they block it, therefore taking the brakes off. And these are examples here in this picture of the most common checkpoint inhibitors. There's PD-1 is a very famous checkpoint, and we use nivolumab and pembro. There's CTLA4 inhibitors, there's PD-L1 inhibitors, but there's more coming down the line, and each one has a nuance to its clinical use. And so there's a growing number of indications. This field really kicked off in the melanoma field, but really has blossomed to many other oncology applications. So what's the clinical impact of when you take away a checkpoint and you have this unchecked T cell response? This was a seminal paper in 2011 in the New England Journal looking at metastatic melanoma, and it was really the first time we saw the addition of a checkpoint inhibitor shift the clinical survival experience to this degree. This was really a revolutionary approach to the treatment of melanoma and has now become the first-line therapy. You have multiple trials really showing us repeatedly enhanced progression-free survival in these trials where checkpoints have become just a superior advantage to all other conventional chemotherapies, or maybe in addition to, with really enhanced survival. So the checkpoint inhibitors have become probably one of the most common therapeutics that we use, at least at the MGH Cancer Center, and certainly that would be used in any other academic or large community hospital would be a checkpoint. Now, if you're enhancing T cell responses to get this fantastic response for cancer, can you do the same thing? This is just as an aside. Can you do the same thing for infectious diseases? Can you enhance T cell responses and get a really robust anti-pathogen response? And the short answer is absolutely yes. And so I'm going to show you just a series of examples where people have used checkpoint inhibitors to enhance responses to a variety of pathogens. One example is tuberculosis, where here we see that tuberculosis, T cells responding to TB express checkpoint checkpoints like PD-1 and PD-L1. And so if you block these, you can see in vitro this enhanced expression and population growing of T cells that produce interferon gamma, IL-2, in response to tuberculosis. So some in vitro evidence that blocking these checkpoints can give you an enhanced anti-TB T cell population. There's lots of theories behind this, but in this review, they're actually, really paralleling the examples of the tumor response to those in TB granulomatous lesions, and that blocking these checkpoints really do enhance the anti-TB response very similarly to what you would expect would be happening for an anti-tumor response. HIV and other viruses have been examined. This is a phase 1 clinical trial using an anti-PD-L1 from BMS. And again, here, sorry for the graininess, but it says change in percent of HIV CD8 positive T cells. And so what you can see is, compared to placebo, you can see an enhanced number of CD8 positive T cells responding to HIV. Hep C is another example where a single dose escalation study in individuals with chronic Hep C received a checkpoint inhibitor where the endpoint was reduction of HCV RNA. And so this was the schematic. And so they did a dose escalation study, and they saw indeed that there were very profound responders where you saw a significant reduction in hepatitis C viral loads. These are in chronic viremic patients. And so by adding a checkpoint inhibitor, you've enhanced an anti-Hep C T cell response, and you saw a reduction in the Hep C viral loads. Other examples, which I don't have time to really go into at this time, include checkpoint inhibitors against malaria. We have examples of histoplasma responses using checkpoint inhibitors. So that, I guess, the take-home message here is that checkpoint inhibition appears to take away the brakes, give you a really profound augmented T cell response, which clearly has become a mainstay in oncology. And while we don't do it in infectious diseases, there's really strong mounting evidence that you could enhance a T cell response to even hard to treat infectious diseases. And the examples, really cross many kingdoms. So we have fungi, parasites, bacteria, viruses. So there's really, it's a broad acting sword, so to speak. And so one thing we need to talk about is the side effects of checkpoints. It's not all, a rosy picture. So we have to also be aware of some of the toxicities of unchecking a T cell response. And so while we've been talking about everything on the left side of this balance, where we want to use checkpoint inhibitors to enhance T cell responses, get better responses to tumors or even infectious diseases, you can really tip the scale to the point where you begin to see side effects that look like autoimmunity. And so often what we will need to do is then add steroids to these individuals to rebalance, the scale and right the scale up a little bit so you can really reduce the impact of these side effects. And if we do that a little too potently, then certainly we can then tip the scale to the right side and now have an immune compromised individual. And that's really where I see most of the infections occur. It's the individuals had a little autoimmunity in response to their checkpoint therapy, and then we add steroids or other immune modulators, and then to really quiesce those side effects. But we go overboard and we now produce a real immune compromised patient because we've given them too many steroids or other anti-inflammatories. And so what are the types of immune-related side effects we can see when you have an unchecked T cell response? And the take-home message here is that almost 30% of patients receiving a checkpoint inhibitor will have some form of a side effect. And here's some reviews where I've tallied the average percentages of the types of organ involvements, which can be everything from colitis, pneumonitis, but really every organ system has been described in terms of having an immune-related adverse event. And these look, for all the matter, like as autoimmune diseases. response. These look like very profound, often life-threatening autoimmune diseases. And we really do need to act quickly in recognition and initiating steroids and other anti-immune agents to quiet this T cell response down. So there's a specific time period when these can occur. They don't occur usually, typically after the first initiation of treatment, but it takes a while for these T cells to really mount, to have this unchecked response begin. And then we see sometimes skin toxicities occur first. You can see GI coming up second, but really throughout weeks to months, you can have different types of organ manifestations. And it really does take a little bit of a village of different subspecialists to really monitor these patients as they maybe present with different symptoms to try to understand if they're suffering from an immune-related adverse event or if this is something completely distinct from their checkpoint inhibitor treatment. And so these are examples where people have noted hepatitis, pneumonitis. This can progress to ARDS level, life-threatening complications where people have been admitted to the intensive care unit. And so how do you prevent this from happening, or how do you manage this when it does tend to occur? And so the mainstay are corticosteroids. And so the first thing is to hold the immune checkpoint inhibitor treatment. And then really what's used are incredibly hefty doses of corticosteroids. These are not small doses at all. These are really intense, very high amounts of methylprednisolone with very prolonged tapers, often out to 2 months, with serial examinations to ensure that someone doesn't progress to more worse organ dysfunction. I'd say the majority of these checkpoint inhibitor adverse events are mild, and they can be managed outpatients with prednisone. And there's a subset of them that require inpatient admission and management for really life-threatening organ dysfunction. And then if corticosteroids are insufficient, then certainly we can turn to other blockers like TNF-alpha blockers and add additional agents to really try to quell this vigorous T cell response. Things that have come up over the years that I'll just share with you are, should we, for example, vaccinate someone on a checkpoint inhibitor? We just talked about unleashing a T cell response. So what if you were to give a vaccine during a checkpoint inhibitor treatment? Would you have this vigorous response that would be unchecked to the vaccine itself, and that can cause an exuberant response and toxicity? And we worried about this quite a lot at the beginning of the immune checkpoint inhibitor treatment era, and then it's been studied actually quite extensively. And at least for influenza, we see that compared to those individuals receiving and versus healthy control, there really isn't a lot of immune-related adverse events to vaccination. We think it's relatively safe at this point. I think other vaccines need to be studied. And in rare cases, there were some pneumonitis or encephalitis, but for the most part, we see that vaccination, at least for the flu, the annual flu, is safe in immune checkpoint inhibitor recipients. Now, we talked about all these organs being influenced and potential, and being able to recognize what's an immune-related adverse event. And so, at least here at MGH, these are complex patients, and we did eventually approach this issue by forming this committee called the Severe Immunotherapy Toxicity Service, or SIC. And you can see Dr. Reynolds is the chair of the steering committee, and each of the spokes on this wheel are individuals or physicians who are committed to understanding immune checkpoint inhibitor toxicity in their subspecialty. And so we have everybody from endocrine, renal, infectious diseases here. It's me. It's actually grown quite a bit. There's more physicians here, including Dr. Sarah Hammond and Alyssa Letourneau, who you'll hear from later in this course. But it really does require a large number of people who are committed to being able to recognize these toxicities very carefully. So again, this is just some more data that I'm going to leave for you showing immune checkpoint inhibitor and flu vaccination, showing that overall it was relatively safe. And so the answer to the question of what is an immune checkpoint inhibitor, the answer is B, an immune checkpoint inhibitor interferes, it blocks with these down-regulating surface molecules called checkpoints. And they're on the surface of immune cells like T cells, and they're meant to shut the T cell response down after the infection is resolved or after the tumor has been taken care of. And so you want that T cell response to shut down. What we've done as a therapeutic is to block that brake. We've taken the brakes off the car and we've let this T cell response run, to much higher levels than normally would be found. And we're doing that to get a more vigorous anti-tumor response. We've reviewed that you can also get an anti-infectious disease response. So that's an interesting sort of theory that I like to think about as an adjunct to difficult to treat infections. Should we be using the same concept for infectious diseases? And of course, we've also reviewed that unleashing T cells, you can often have, adverse events such as autoimmune manifestations in multiple systems. So these are checkpoint inhibitors. In the last part of the talk, I'm going to quickly go through CAR T cells and then we'll close. So the other immune modulating treatment you would likely encounter are cellular therapies. So we were just talking about antibodies, molecules. These are cells, okay? And so what are CAR T cells? Is the question which we'll review at the end. But are CAR T cells the patient's own modified T cells? Or B, they're naturally occurring T cell populations that are identified in the patient and expanded for therapy? Or C, they're completely artificial, they're a synthesized T cell that is like a Frankenstein T cell that we make ourselves and has nothing to do with the patient. And so CAR T cells, which stands for chimeric, that's the C, antigen receptor, CAR, CAR T cell. This is personalized medicine, okay? So here's part of the answer. This is the patient's own T cells, which are harvested during a pheresis run. And it's sent to a central processing lab. There's many around the country. And then that individual's T cells are then engineered to express this unnatural chimeric receptor, okay? Those cells are then expanded to large numbers, and they're sent back to the hospital where the patient's being treated and they're infused. So this is just a quick schematic of what the chimeric receptor is that's being inserted into a person's T cells. And so they're composed of basically three components. There's an outer recognition domain. And so this domain comes from an antibody. So let's say this chimeric antigen receptor recognizes lymphoma. It recognizes CD19, okay, on the surface of B-cell lymphoma. This is the recognition domain. Then you have a transmembrane domain, which is attached. And then you have a third component, which is a signaling domain. And so instead of going through signals 1, 2, and 3, like we just reviewed as a natural immune response, we've engineered this receptor to provide all those signals at one time, okay? So upon recognition of your target antigen, you will deliver all signals into this T cell and activate it. And you get a vigorous CAR T cell response against whatever antigen you have built and engineered the recognition component. And so here's a schematic of how this occurs. The patient is admitted. Most CAR T products are FDA approved for lymphomas and multiple myeloma. So let's say this person has lymphoma and they're not responding to conventional chemotherapy. You can then pherese their T cells and send that cell product to a group that will then take those T cells, expand them, add in the modified CAR receptor, which is now expressed on the surface. They'll prepare them, send them back to the hospital where this patient's being treated, and then they'll be infused, okay? And so to infuse CAR T cells, you do need to give this patient some chemotherapy to condition them and prepare them for the infusion of the CAR T cells. So there is some chemotherapy associated with CAR T treatment, and then the CAR T cells are infused. They'll enter the patient's body. This is this person's own T cells. They just happen to now express a receptor that will recognize lymphoma. And so you're targeting You're personalizing that person's T cell response to their lymphoma. And so what happens when you see that, when you do that? It's been really quite miraculous. So this is two schematics of PET-CT images. And so before treatment, you see that there's intense FDG uptake in multiple organs. And then, after treatment with CAR T cells to this lymphoma, you can see that there's really a really impressive regression of all these tumors. Now, when you're infusing all these CAR T cells, what can happen? T cells produce a lot of cytokines in addition to killing tumors. And so you can get a really robust release of cytokines. So we've termed the syndrome CRS, or cytokine release syndrome. And so you really have to be careful for that when someone has it. We'll talk a little bit about how you manage that. So CAR T cell therapies have really revolutionized response to lymphoma and multiple myeloma. There have been other studies where adding a checkpoint inhibitor, the same checkpoint inhibitor we just discussed in the first half of this lecture, to a CAR T cell therapy really provides even further enhancement of T cell response. So here we've taken CAR T cells which do express checkpoints. And so by adding a checkpoint inhibitor and removing the brakes of this chimeric antigen receptor recognizing T cell, you can now get an even further enhancement. And so there are studies such as the one I'm showing you here on the screen, where people have taken, really refractory tumors and lymphomas and added a PD-1 blockade to enhance the CAR T cell response with good clinical outcomes. So there's really a lot of tools where we can now see that enhancing T cell responses can really result in very profound, amazing oncologic responses. Now, this, of course, similar to checkpoint inhibitors, this comes with side effects. Here, I just before I jump to that, I'm leaving you with this slide that shows you a summary of multiple case series and findings showing really the dramatic response to lymphomas. You can get everything from 60 to 90% responses in refractory lymphomas to CAR T cells. And in fact, this is, to the best of my knowledge, the most up-to-date list of FDA-approved CAR T cell products. 4 under lymphoma, and then 2 under multiple myeloma that are currently in commercial use for these tumors. And more are coming down the line. We know on a research level, there are CAR T cells being produced to solid tumors as well as many other indications. So what happens when you have a CAR T that is infused back into a patient that responds to the antigen on that tumor that it's targeted for? And you get this vigorous anti-cancer elimination. These T cells produce, as part of their activation, cytokines. Cytokines are hormones in the immune system that signal one immune cell to the next, or they can have long-range effects. Those can be things like interleukin-6, TNF-alpha, interferon gamma. So those are cytokines, and these cytokines can have really profound impact on a patient. So what clinically could you see when you have a lot of cytokines being produced by these CAR T cells? You can have fevers, rashes, patients can present with diarrhea. You can have very syndromes that look very similar to sepsis or septic shock. You can have mental status changes. And so we've taken these clinical manifestations and we've graded them. And so there's grades of cytokine release syndrome. And certainly when you look through these, you can see that initially they can be very mild, for example, just having a low-grade fever, and they can progress all the way up to requiring oxygen, intubation, vasopressors, or really be life-threatening. So how do you manage CRS? So it turns out that initially we approached this issue similar to an immune checkpoint inhibitor toxicity, and we added a lot of steroids up front. We weren't getting the best response and the best management for CRS with steroids. And then there were studies performed that looked at proteomic analysis of patients' plasma, and it turns out that interleukin-6 is one of the main dominant cytokines produced by CAR T cells in the setting of CRS. And so tocilizumab, which is an IL-6 receptor blocker, became the mainstay of managing CRS. And so now it's really providing tocilizumab to block IL-6. And if you really don't have a sufficient response to tocilizumab, you can add other things such as steroids or anakinra for like IL-1 blockade, and you can really pile on additional immune agents, immune blocking agents. Now, in this, similar to immune checkpoint inhibitors, when we begin to dampen immune responses to manage CRS, we can now also result in an immune compromised patient. And so when someone comes in with a grade 3 or 4 CRS, and we're really adding a lot of immune inhibiting agents, toci, steroids, et cetera, we can see infectious complications, and we have seen pneumocystis, bacteremias, and both viral and mold infections in this setting. So something to be aware of when we're consulted and we're looking at someone who's receiving CAR T cell therapy. Where are they in their treatment? What side effects have they presented with? What's the management of those side effects? And if it's severe enough that we're adding very serious agents such as anti-IL-6 and steroids, and things are really piling on, we do need to be aware that this person is really becoming a very deeply immune compromised individual. One thing that was under-recognized in the initial use of CAR T cell therapy is that we're eliminating not just lymphoma, B cell lymphoma, but probably a lot of other B cells, normal B cells. And so one thing that we began to see is that individuals were experiencing hypogammaglobulinemia. And so this was a study done by the allergy immunology group here at MGH. This is a slide courtesy of Dr. Barmettler and Farmer. This has yet to be studied, but has been submitted for publication, the last I heard. And what they really recognized is that the initiation of a B cell specific CAR T cell often resulted in really profound low levels of IgG due to B cell aplasia. And so when they looked at the immune globulin levels following CAR T cell therapy, what we saw is that the number of patients who had mild hypogam before CAR T cell really increased, and you saw a spike in the moderate and severe levels of hypogammaglobulinemia. And so this is just another indicator and metric that we need to follow following transfusion of CAR T cells is IgG levels, and protocols around replenishing and using IVIG are critical to really curb future infectious events because of low IgG. And so they did actually do that. And so IgG levels decreased after CAR T cell therapy. They correlated that with an increase in infectious complications. And those infectious complications were increased when you saw really severe levels of IgG less than 400. And so the question of what CAR T cells are, the answer is A, these are the patient's own modified T cells. These are T cells from the patient themselves sent to a company, which then modifies the T cells to express this chimeric antigen receptor targeting the tumor that the patient has, be it a lymphoma or a multiple myeloma or other tumors to come in the future. And so to conclude this lecture, we've reviewed several things. We reviewed what a normal immune response looks like at a very high level. We've reviewed that T cell activation must come to an end, and that those breaks that will slow down that T cell response are called checkpoints. We've taken advantage of that by inhibiting those checkpoints. We've removed the brakes off those responses and seen really profound T cell responses that have been dramatic, certainly in the field of melanoma, but many other tumors. So we're getting really profound anti-tumor responses. In the cellular therapy world, we've definitely seen major impact in taking one's own T cells, adding and expressing these chimeric receptors, and we've seen this person's own T cells now enhance killing of lymphoma and multiple myeloma. Both of these therapies definitely overcharge the immune response. They definitely enhance T cell activation, and they both result in these immune-related side effects. In the setting of immune checkpoint inhibitors, we've seen every organ essentially present with autoimmune-like syndromes, but more commonly it's skin, GI tract, and lung, but every organ has been published and described to having an autoimmune phenomenon. And with CAR T cells, it's really cytokine release. It can be very profound and look like septic shock, in fact, and require ICU level care. And it's the management of these adverse events, these immune-related adverse events, which often leaves our patients for very high-risk infectious complications. And we just need to always be aware where this patient is in their treatment, what they've received, what they've experienced in terms of side effects, and how that side effect is being managed to really understand on the spectrum of immune risk where they are, so we can understand what infectious agents they may be suffering from. I will also mention that CAR T cells recently have started to carry a new warning. There was a recent FDA warning that CAR T cells have been linked to future T cell lymphomas, and so there's other side effects that are coming out as we use these agents now, including secondary cancers that have been noted when we use CAR T cells for lymphoma specifically. So with that, I would like to thank you so much, and I look forward to your questions during that Q&A session.